Good afternoon. I'm Dr. Andy Anderson, and we're here to discuss the topic of Alexa, not Alexis, my fellow panelists, Alexa, where's my healthcare, and how technology and science will impact and improve healthcare delivery in the coming decades. I'm Dr. Andy Anderson. I'm a member of the Texas Biomed Board of Trustees. I'm the immediate past vice chair, and I'm excited that I've been asked to moderate this panel. And let me begin by welcoming and profusely thanking our panelists, beginning with you, Alexis, Dr. Alexis Wiesenthal-Miles, a Mayo-trained internist and primary care provider in our metro area who uses technology extensively in her practice. Thank you for being here. And I'm not sure if we have our virtual participants, Dr. Zaim Haq, the Global Director of Medical Services for Save the Children. Hello, Zaim. You're a star at the center of the healthcare stage in so many developing regions. Thanks for joining us, Zaim. And finally, Pravi Bhatt, who brings the unique perspective of a global healthcare executive and is now working in targeted philanthropy for unique solutions to healthcare delivery and its current challenges. Thanks to all of you for being here, and I hope we have a great dialogue, which I'm certain we will. Let me begin with you, Alexis. Please share a little bit about your practice. You were telling me some of that before we started our panel, how you're currently using technology and where you see it going.
Thank you so much, Andy. I'm Dr. Alexis Wiesenthal-Miles. I'm an internal medicine doctor, and I focus on preventative wellness and primary care here in San Antonio. I'm originally from San Antonio, and so it's so wonderful to have the Global Health Symposium and Texas Biomed just be right in our own backyard. I've been a supporter of Texas Biomed for many years and part of the Founders Council, which is the young professional group of people who support Texas Biomed and are community advocates for Texas Biomed and help with raising funds. And specifically at the end of the year, we use our funds to donate an equipment grant for the Texas Biomed scientists. So during the year, they tell us what they really need, and we work hard to raise money to get them whatever equipment they need. And that's really fun to present that at the end of the year. I'm excited that I'm going to be president-elect of Founders Council next year, so I look forward to continued leadership in Texas Biomed and maybe even be on the board with you one day. That would be awesome. So I have just been really impressed with how we have been able to harness digital technology in this time of increased need for delivery of innovative healthcare ways. So obviously with the advent of the COVID-19 pandemic, there was need for expansion of telehealth. And telehealth isn't something new. It was actually started in the 1960s and was used mostly in outer space and for military medical treatment. But we've had the opportunity in the past 2 or 3 years to really rethink the ways that we can deliver healthcare effectively to more people, and to deliver healthcare to underserved or unserved populations. So, one of the purposes of this Global Health Symposium is to bring us together to discuss ways to equitably distribute healthcare to the global population. And I really do think that telehealth has the opportunity to help us build health equity through community, trust, and science, which is the basis of this platform. So I have seen that digital healthcare has really offered increased access to many of my patients who often have to find childcare to be able to make an appointment, who have to take off a day or a half day of work, find transportation. There's a lot of limitations to, not just people in other countries, but to our neighbors for getting to the doctor. And so digital health offers increased access in that way. Telehealth also plays a role in environmental stewardship. And it's thought that 8 to 10% of carbon emissions are healthcare industry driven. And so with the advent of telehealth, there's been some studies on like how many carbon emissions have been saved by patients not hitting the road to go to the doctor. So there's a positive impact on climate change and greenhouse emissions and carbon emissions from the healthcare sector. And telehealth cuts costs of, travel, loss of productivity, and also decreases emergency room visits and readmissions to hospitalization. So how effective is telehealth? Like, is this safe? Is this good? Like, should we stick with this? So there's been some studies from the National Quality Forum. That's one of the ones that like the HEDIS data uses, Healthcare Effectiveness Data Information Set. And that's one of the ones that like insurance looks at and, quality care measures for rating physicians and hospitals and all of that. So they measure those health performance based on importance, scientific acceptability, feasibility, usability, and competing measures. So the NQF quality core measures found that in 13 of 16 of the HEDIS core measures that telehealth actually outperformed in-person care. Yeah. So telehealth was more likely to meet the HEDIS quality measures in all the counseling and testing-based measures, including preventative wellness, vaccinations, cardiovascular disease, diabetes management and testing, depression, and cancer screening. So yay me. Just kidding. But anyway, I'm really excited about the future of telehealth and some of the remote patient monitoring devices that can help us interpret large amounts of data and import that into the electronic medical record system and really offer physicians real-time monitoring of patients in their own environments, in their own homes, wherever they are, meet patients where they are. So that's what I would like to see.
Fantastic. One quick follow-up. How do you see our progress with electronic health records and the health information exchange integrating with telehealth? Is that, from a provider standpoint, is that working at all now, working a little bit, lots of work to do? Where are we on that dimension?
I mean, it's so dynamic. So, doctors aren't necessarily technology trained individuals, but I'm learning. And so I have really leaned on my electronic health record. It's eClinicalWorks. It's kind of one of the big ones like Epic and other ones. But they have a lot of integration with some of these remote patient monitoring devices where say you have your Cardia portable EKG machine. That data can directly import into your file and send me a note. You have a new strip to review from your patient, or the Omron blood pressure monitors. I'll tell a patient, please check your blood pressure 3 times a week, and then upload your data into the portal. And then, it makes these incredible graphs, and, the patient can put, just had worked out, or, I went for, a giant bag of pretzels or whatever, and we can try to figure out some therapeutic lifestyle changes they can make for blood pressure control. So I think it's a lot of information, and it can be overwhelming, but some of the AI technology can help us bring these together, and I can provide higher quality care with more data.
Great. Parvi, will you get in here and help us understand how you see it playing out in the communities that you partner with, and in some cases those that may have fewer resources or have trust issues with the healthcare system?
Sure. Hi. Well, hello, everybody. All I can say is I'm coming to you from Minneapolis, a balmy 48 degrees. So I really wish I was there. And my 13-year-old self is mortified that I am on a jumbotron in front of all these people that I cannot see. So I'm thrilled to be here, and I will calm that 13-year-old down. I just love the title of this session. And the reason why is where I'm going to come back to in a quick second. My background has been in global health for most of my career. It has been in moving capital closer and closer to partners who are actually delivering services closer to the doorstep, because tertiary care isn't as evolved as we assume it is in this country. And so there's a lot of systems that have been built up. Where this all came to a screeching halt for me is when I had to take care of my mom at home. So I've been in an executive in global companies, global nonprofits, federal government, all the way across. And I was flat-footed when it was time for me to take care of my mom at home. So when I look at the title of this session, I was screaming that 2 years ago. Where is my healthcare? And so I think it's really important to come back to that, to really appreciating when we're not thinking about healthcare delivery, we're actually thinking about healthcare receipt. How are we actually accepting healthcare? Are we actually taking on the advice that's being given, the therapies that are being given? And at the end of the day, I think we all can say, whether you're trained in healthcare, I'm trained in public health, that we joined it because of the personal connection. And so the debate that's in front of us is, where does technology end and where do we begin? Because at the end of the day, we still want that interaction that is tactile when it comes down to care, because care is delivered and received through people. So in my experience, that's been the issue. It's been around, how are we making sure that we're liberating time, inspiring skills, ensuring that people receive a fair wage, so that when they're a part of the pathway of care, wherever you are in the world, including in the United States, once someone enters your home, that they have everything they need to be able to take care of you. And that includes home health aides that we might be talking about in this country. Like I said, I was flat-footed, having done so much all around the world, to now have my first generation Indian immigrant mom that I'm trying to take care of after, as a second gen Indian immigrant, go all the way back to India and spent most of my career in a country I didn't even grow up in, to come back here and be like, oh my God, who was I to be doing anything over there when I don't even understand how to leverage care here? And we faced worse problems here. So a lot of it was really understanding where the limit of care is. So what we heard earlier, absolutely, right? It made it so much more convenient for someone like me, who wasn't super sick, but to be able to still keep myself healthy as I was taking care of my mom, because telehealth allowed for it. And now value for time, right? All of us are busy, and we've all complained about having to wait in a waiting room. Now having telehealth allows us to actually have some democratization of everybody's time, which is important. But what we're seeing now is hospital at home, these amazing ideas that have come from the great energy of, we were all at home taking care of each other. Some of us still are. That said, if you look at the promotional side of things, I encourage you to take a look at the promotional side of what's happening with hospital at home. It shows a very able elder who is very ably able to look at a screen and engage. And that might work in a preventive setting, but hospital at home means we got discharged a little bit early and we're able to get home. And I don't know about you, but if you've ever been that family member at the bedside when mom or dad is ready to get, or son or daughter ready to get discharged on a Friday, deep down, you're hoping it's Monday so that you have that weekend to get ready. Because you've got somebody has to be there. And so with my broader perspective now, and I've been spending so much time around the world worrying about care at home, it's here that we've got a lot more to do when it comes to what is it going to take to bring care home. And when we start to disrupt the way we think about research, and we start to think about it not from the clinical space only, but action research, and much of what we see startup businesses doing, if you were at home and you were to rebuild the health system from there, where I wish I had that opportunity a couple of years ago, and you ask not just the person in need, but their family, we would come up with something entirely different. So have we brought all of the tools of research, qualitative as well as quantitative, action research, the innovation process, not about a product, but about the referral pathway and the partners that we may need to bring truly culturally relevant care at home? And then have we really enabled the actual people who deliver care in a way that we can still come back to why we joined this field in the first place? It really was so that we would be eyeball to eyeball, being able to hold someone's hand as we're trying to clarify what we need to do next. And so I think we've got some important caution as we think about this and really optimize, where is it that we need the most help? And I'll end on this. I think absolutely remote patient monitoring is helpful as long as we're monitoring the right things. I know for a fact my mom did not want to do a lot of those things. I had to force her to get on the scale, make sure we get the blood pressure right, system failure after system failure. I worked for a company that developed those, so I'll own it. It doesn't always work, right? I mean, we're lucky we can even be on this Zoom together. We know sometimes it doesn't always work. And so what are you going to do when it doesn't? And we know, of course, that broadband and all sorts of things are not equitably delivered in any part of the world, including here. So there's a lot of other systemic things that need some attention. And the financing has to support that. And we've got a long way to get there too. But this is the first step, and that's why it makes it exciting. But now's the time to ask the questions.
Well, thank you. And I love how your personal experience is informing your perspective on policy and allocating capital. Zaim, come in here and discuss, from the frontier of healthcare, where you sit, particularly the likely impact that these developments will have in more resource-constrained geographies that you serve.
Thanks, Andy, and good afternoon, everyone. I hope you can hear me all right. Okay, perfect. So I'm dialing in from London, not on the front line today, but my broadband connection is perhaps not the best, so please bear with me if something goes wrong. I hope not. I have been working in global health for like 20 years, and we work in places where we don't always have all the tech or all the technology or access. We work in places where we don't always have the infrastructure. So the tent you see behind me is what we set up during the Ebola outbreak in West Africa. We were treating patients, or generally in any crisis, any emergency, we are treating patients in a tent or in a prefab structure. So we lack infrastructure in developing countries. We lack human resources for health. We lack the access to technology. So there's a lot of challenges that we have to face in terms of improving access to healthcare. But let me go back, as in terms of inequities, places where we work, Save the Children works in over 100 countries around the world, and not everyone has access to healthcare. According to WHO, we've got more than 400 million people around the world who do not have access to even the basic healthcare services. That's more than the population of the United States. There's a lot of people still struggling to survive or having basic access to healthcare, which is a huge challenge. And we work with governments or ministries of health to try to improve their access to services for their people. We know universal health coverage is one of the biggest challenges today. And despite all the efforts of the past 20 years of Millennium Development Goals and now working towards the Sustainable Development Goals, we had the COVID pandemic in the last 3 years. And perhaps all of that progress was not only stopped, but in many places it's regressed, it's gone back again because of the challenges of the pandemic. So in some ways, the global health challenges that we were addressing over the past 2 decades the progress has been wiped away in many places because we have been reset in some ways, gone back to where we were starting from. But there is still hope. Obviously, we've got a lot of technological advances. We've got a lot of new tech solutions which we are applying to improve access to care. We've talked about telemedicine, telehealth, and that's one of the biggest changes now. We see surgeries being conducted by a surgeon sitting in developed countries and accessing robotics or new technologies to improve access to specialized care for patients thousands of miles away. That's a huge thing. I mean, Save the Children is not involved in those specialized care. We deal with the basics, and even small little technological solutions such as a respiratory timer, which requires a small little battery. It enables a community health worker to identify a case of childhood pneumonia. And just by knowing this is not a normal fever or any other illness, it is pneumonia because of the breathing rates, they are able to treat it with really simple antibiotics, and the children survive. So we have been using those simple technologies for a long time. We obviously have newer technologies now. The AI can revolutionize access to healthcare for children or mothers in villages across the developing countries. These are places where there is no health infrastructure, there is no clinic, there is no doctor. So communities rely on community health workers or sometimes village doctors to access healthcare or to survive. So there's a lot of work we do. We have over 120, I think 121, I was counting the projects we currently have, that involve digital programming to improve access not only to health and nutrition services for children and their communities, but also for education, to improve their learning attainment, or to improve safeguarding or protection of children, to improve livelihoods of communities. So digital solutions or technologies are enabling us to improve people's behaviors in communities across the developing world. We are able to reach more people. We can sensitize more people in terms of improving their healthy behaviors or practices, bringing mothers to clinics for their vaccines of for their children. So there's a lot of advances. I think I can't cover all of those. Maybe I'll end in the last on the last point around supply chain, and that's one of the areas which I look at through our pharmacy services as well. And the advances there have enabled international organizations such as ours to improve access to medicines, access to vaccines in places we would never be able to get supplies on time, life-saving supplies on time. So that's a quick background on where I'm coming from. Back to you, Andy.
Thank you, Zaim. That's terrific information for us. And you mentioned AI, and when I think about the most important recent developments, none is more top of mind than AI and large language models, machine learning, that sort of thing. And so selfishly, I would love to hear this panel's thoughts on how this might change healthcare in the coming decades. In two specific areas, really, I'd like to hear your thoughts. One is development of vaccines and therapeutics, as well as the manufacture and delivery of those. And then secondly, in terms of infectious disease surveillance and our potential responses. All this as it relates to AI-type topics. Zaim, let me let you take a crack at it first, and then we'll rotate to Parvi and then back to Alexis.
So I think that's a really important topic to explore, and AI is only evolving or developing as we speak. It's only been throughout the pandemic, and quite recently in the last year or so, we have seen more and more developments on AI being applied, practically enabling us to improve access to healthcare. I think I would start with the infectious diseases. In terms of our ability to monitor or track the epidemiology of disease, especially in a low resource, low income setting, and our places where we don't have epidemiologists, not all of our developing countries in those contexts, we have epidemiologists studying trends of disease or outbreaks across the world. And we've seen that quite recently with the pandemic. Not everyone could track those cases, especially the spread of disease and how we could control that effectively. So there's a huge challenge in terms of our human capital, our human resources on ground to be able to track disease spread or effectively control it. And perhaps that's where AI could potentially help identify those hotspots or potential spread and for enabling us to be better aware. So with the surveillance systems in place or with AI technology, we could be better prepared in terms of responding or being ahead of the curve with for the next pandemic, hopefully. And then in terms of vaccines as well, there is a lot of brilliant examples with the COVID pandemic. We've never seen such a rapid development of vaccines as much as we've seen quite recently. And there is a reason. So there's a reason why everyone invested extensively in development of COVID vaccines, because the whole world was at a standstill, and there was a huge interest in ensuring these vaccines were developed so we could resume our businesses, resume our normal activities. And we've seen a lot of other diseases, tropical illnesses or chronic illnesses out there, where we've not seen enough sufficient investment in those vaccines being developed or medicines being developed to try to eliminate or eradicate those diseases. But again, artificial intelligence has huge potential, I think, for both of these areas to enable us to both not just develop, but also roll out vaccines or medicines for these illnesses.
Harvey?
Great. I think I'm just going to pick up where Dr. Zam left off, which is on the rollout side. So, and kind of go back to where I opened from. I think this is, again, because it's this new, this is also the time to ask the right questions. This isn't a time for us to take a back seat and basically, delegate our brain. Because as this is getting, more fueled, as we're getting more and more inside of what's happening with artificial intelligence, I think we also need to keep an eye on the ethics of how we use it and what's informing it. It's an interesting behind the bench question, but the reality of it is, as we've already seen, is bringing a lot of people around the table to say, well, at what point do we need to be concerned about it? So I think in healthcare and in medicine and in discovery is where we're going to need to be really intent on that. That said, there's a lot of efficiency gained. Of course, in the capture of information and the initial analyses of it, again, it needs to be cross-checked by those that are closest to the ground, which requires the human mind again. But also in the delivery of care and, again, the acceptance of care. We can take a lot of the transaction costs out of this if we've got a way to ensure that front line that we were just hearing about, the community health worker, the home health aide, whatever is called the front line, wherever you are in the world, the family member sitting at the bedside, if they're trained and quickly are able to know how to use ChatGPT and AI, and we all do now, that we know how to access it well and it's able to provide us basically in lay terms what we need to do. The issue is going to be I believe, what we saw with the vaccine. Who will really trust it? And when things become aggregated to a greater body, a lot of communities that have been marginalized and have historically not received care, which is what the larger global health question has always been about, will always face this moment of, can they trust it or not? And it'll come back again to that worker that is inside the home, whether he or she can trust it first, and then able to translate it to the care that we need to deliver. So for me, of course, yes, behind the bench, there's a lot of help that we will get from it. And again, efficient help in the initial phase of rollout as well, but not without a really strong set of questions that we're constantly asking it and informing it, and an ethical kind of ribbon around it to make sure that we're still engaged. My fear is at the pace of change, we're going to sit back and let it take the lead. And I don't think that's why we all have professional oaths not to do that. So how to make sure that we stay engaged and informing the future delivery of it.
Thank you. Alexis?
Thank you. I think AI is a really exciting frontier and obviously very topical in the news as well. And some of these AI powered remote monitoring systems have the potential to transform chronic disease management and improve outcomes and reduce healthcare costs, and can help provide real-time insights to complex medical conditions. I know that some of us use like a Fitbit to track different metrics as well. And then there's additional AI technology even being used to help diagnose skin cancer, like diagnosis biopsy from a dermatologist or AI, which is better. And then there's some other like smartphone technologies, like for people with chronic obstructive lung disease or asthma. There's one called Hife that ambiently tracks your coughing and can transmit that information to your provider and kind of predict when you're going through a pulmonary flare and get on top of that. There's one for seizures called Seize Alarm that is a smartphone application that tracks movement and heart rate to detect seizure-like activity and puts out emergency contacts and gets in contact with your care team. And then there's Lumen. It's like a standalone product that uses your breath to track metabolism. So that can be, helpful for athletes and things like that. And so there's just a lot of exciting directions that this can go, scary directions too. And, you worry about health information, patient privacy, compliance, and things like that. But having some of this accessibility to this amazing data set is really exciting and has a lot of potential power to harness and respect.
For sure. I have to confess, I actually asked ChatGPT to generate a list of the 15 topics we needed to cover in this talk, and so far we've gotten to about half of them, so we got a little bit of work left, some wood to chop before we're all done here today. One of my activities is with a pediatric provider company that has a niche solution for the delivery of both sick and well care to pediatric schools through contracts with the independent school districts. And they currently serve over 250,000 students. And my work with this business has made me aware of how important social determinants of healthcare and health really can be in the disparity that we see, but not only across school districts and geographies, but one school to the next. Very different picture. It's also been quite interesting that the delivery model we have in that business is terrific, but the receipt of that model, to your point, Parvi, is suboptimal at this point. And so there's some friction and resistance to technology providing healthcare solutions that I'm personally acutely aware of. So I'd like to get the panel to discuss a little bit more in depth what Parvi's point is like we've got to get on the receipt side of this issue, and what are the key success factors to actually getting the folks that we're trying to help to accept the approaches that we have available for them, and how do these topics that we're discussing help close the chasm in health equity that we're seeing. So let me go back around the other way and start with you, if it's okay, Alexis. Thank you.
Sure. I feel like the keynote session with Craig Noonan addressed some of this yesterday, particularly delivering healthcare to schools. And one of the things that he's doing is bringing telemedicine to individual schools to have higher levels of care available. So basically, like a school nurse is more of like a triage section, and then they can zoom in the parent, when the kid comes into the school nurse, and then if they need to, they can escalate to a telehealth physician and have that whole care team there with the child in the school, so the parent doesn't have to leave work, and the doctor can see multiple patients and everything. And I thought that was really fascinating. What was the question?
Well, just and then closing the health equity gaps through not necessarily only the schools, but what do we have to do to successfully increase the utilization and receipt of these technology-based solutions?
So
what's really happening at the bedside or in the bedroom, as the case may be?
He was saying have a trusted community leader adopt some of these technologies. So it doesn't have to be a physician or a nurse or anyone medically minded. It just needs to be a trusted person of the community who can be a beacon for access to people. And so in some of the communities he was talking about in Africa, that their main thing was to try to make a connection with a trusted community leader and then have that be the access point, because healthcare delivery is so much about trust.
Harvey, how about you? I know this is a really hot topic for you.
I think it's hot for everybody. The way, after spending so much time, and I'm sorry I missed the keynote yesterday, but in those settings that I can imagine, and like I said at the top, I was raised here, even though I was sent to India to do things, right? Just acknowledging with great humility who is likely to have the greatest agency to be able to carry any information forward to a family in need. And I'll say again, based on that personal experience that I shared, it was the first time after all these years working on the HIV response and so many other things that I realized actually health is the one thing that all of us, caring for someone is what all of us are here to do. And so when we start to professionalize it to such an extent, I think we lose a lot in what the empathy that we can bring in this. So the reason why I'm going at it this way is none of us sees ourselves as a patient. No one who's a family member sees themselves as a caregiver. So when we take those labels away and we think, well, what would it take for me to take my vitamins every day, which I'll tell you right now, I don't, right? That it is a big journey to get there. And the journey is because we all know, if we realize that all of us are consumers of health, that the influencers for us, the traditional clinical health system is one part of it, but it isn't usually the one, at least I'll own mine. It's not the one that allows me to cross the line. It's usually a friend of mine or an elder of mine, or someone that looks like me that has been on the same path and journeys. And that's me. So that only extends even further when we go into communities that we're not resident in, and in sorting through how to co-design what it would take versus coming ready to just say, okay, I just need you to move this to the next phase is very different than we have a shared problem that we're trying to solve together, which is the uptake of pick whatever it is we're trying to do, and get underneath what the trust and acceptance issues actually are, and not be on the other side of that trust issues and disclaim and just not allowing for it, realizing, well, that's their issue. So what is it that we need to do together to bring things forward? A lot of this is not in the medical space as much as it might be in the social sciences, and that's the cross-sectoral work that's essential. And I, just again, very biased, but I will say that the HIV movement actually had no choice but to handle because of where it began and where it's moving from. And so that right-based effort and noting that the community that's most impacted needs to be a part of crafting the pathway. Without that, I can't imagine that we're going to get much further than we have today.
Thank you. Saim?
I think I'll pick up where Parvi left, and especially the socioeconomics of communities the social services. I think that's the side we normally, from a medical perspective, don't engage because we're so worried about the health system or service delivery. The uptake can only be there if there is that demand, if those behaviors are addressed, if the health seeking, the pull is there as well. There's also the economic side of things, and I think that plays a huge part in people being able to access care, quality care, free at point of use. So where healthcare has been commoditized, we see the uptake is not necessarily the same. And especially in developing countries or in low income settings where you have to pay for healthcare just like any other commodity, there are communities or sections of society who are struggling either to put food on the table or pay for the medical bills, for example. That's where we champion or we call for universal health coverage. So every community, every country, every person, every child should have access to healthcare regardless of their ability to pay for it, or especially it should be free at the point of use. And again, I want to go back to COVID. There's so many examples from COVID because that exposed all of the challenges we had in healthcare. There were countries who were able to afford vaccines quite quickly. And there were other countries who could not pay for the vaccines for COVID. There are still some countries who don't have enough uptake of vaccines. And it's not just the commodity side of things or the ability to pay for it, but it's also the hesitancy we've seen. So socioeconomics, people's perceptions or attitudes or awareness or education, literacy, so there's a lot of barriers or challenges around people's uptake of healthcare, and which then leads to their health outcomes as well. You would see impoverished communities perhaps are lagging furthest behind in terms of their health outcomes or their longevity. So these things are all linked up. There's no medical solution for healthcare or longer term health outcomes.
Thank you. Well, let's get the audience involved, both here locally and virtually. And let me, do you have questions for our panel?
We have one online as well. We'll make time for that too.
Thank you guys for an exciting panel. My question is, so one of the big frustrations patients often have is access to care during urgent care needs. So when they're acutely ill, trying to, see the doctor to figure out urgently what's wrong without spending like $500 and waiting forever at the urgent care center. How does telehealth, aid in that problem and getting people access?
I keep people out of the emergency room all the time. They're like, I'm on the way to the emergency room, but I thought I'd go ahead and give you a call to let you know. And I'm like, tell me what's going on. And then I'm like, okay, instead of going to the emergency room, go to Walgreens and pick up the prescription that I just sent in. So yeah, absolutely. There's a lot of times that we can de-escalate use of the emergency room for, what it's really needed for, which is, if you need a cardiac catheterization because you're having a heart attack or, you're having a stroke and need an embolization. So every day I'm just like, oh, yay, I'm so glad I could help this person right away, or even something small like I have a urinary tract infection. I got you, girl, So definitely the immediacy of telehealth is great. Or just this morning, somebody had a really painful rash that came up and they just woke up with it. And I was like, yep, that's shingles. And so she got to start the shingles medicine, within 20 minutes of the rash appearing. And so she's going to have a much milder course. And she had gotten the shingles vaccine because she was a patient of mine and she's over 50. And so, telehealth is good about vaccine recommendations. So anyway, great question. And, telehealth offers immediacy of care and helps reserve some of the precious resources for the emergency room and hospital visits for those that really need that in-person care.
I think that this is the key to telehealth, really, because of our cost problem in the healthcare system, and we overspend on so many cases, and the more we can divert from the ER, and you're taking it a step backwards, even divert from the urgent care tier of care, which is a lower acuity, lower cost stop. Providers are getting paid on the pediatric side, I know, getting paid $150 or $170 to see those cases, and that's not very much money for the service, but it's the payers love that, because just keeping people out of the OR is tremendously important to our healthcare cost. So that's number one, but I think it just really comes back to this trust issue and people's familiarity with technology, their comfort in using devices, their access to quality internet for imaging. There's just so much we can do, and this was something, Parvi, you talked about in our session before today, where we kind of planned our meeting. The rate at which we're moving forward with technology is outpacing our patients' ability to use our technology tremendously. And so how do we get that more synced up is a big part of what I hope you're investing in, all of us, in the work we're doing. But where does that need to go, Parvi? How do we close that gap from your point of view?
It's interesting because when you look at it from technology, so there's the rate of change in health tech and the rate of, as you said, the rate of basically health tech literacy from the family and the person affected view. And even Dr. Alexis said, clinicians themselves are behind lay people in catching up on technology. So I think we can all own that we've got a lot that we need to get comfortable with. But if you look at the tech sector, they'll say healthcare is so far behind. So we've got a cascade of different industries, different segments that are moving at different rates. So when you look at AI and where that came from and how fast that happened and how we're trying to keep up in healthcare, the next thing has already happened in technology, right? And it will move faster to us. So technology is moving faster than the pace of change in healthcare. Both of those are moving faster than the pace of change of us. So to square that off, I think is just take a breath. Allow for some of this to settle in so that we can figure out what do we keep and what do we discard. Not all of it is good, right? Not all of it is going to get us to where we need to go. And we still have human accountability and human experience that needs to come into this and keep coming back to that. So for me, it feels that now is the time, like I said earlier, to ask the right questions, get different forms of research in front of us so that we can use this as a pilot moment, because this has happened so quickly and is squarely in front of us, to really get our arms around what is working and what's not, because the next one is coming. If we were to meet again this time next year, it won't be ChatGPT that we're talking about. It will be something else, right? So what do we know today that we can already list the questions? And what can we start to do now to get around it? So that's what I think is just full ownership of us and appreciating that we are in the same equation that we're trying to analyze on the outside. And we know that we can only take so much change at once. And how do we study that very, very quickly without worrying about an RCT every single time? I have to say that as a business person and someone who's trying really hard on the ground to get things invested in and to move forward. How can we get there faster with proxies?
Well said. We have another question?
We're almost out of time. Real quick, Janice notes that telehealth seems like it would address a lot of issues that are more transportation, people that don't have transportation or people that don't have a phone to make the appointment, or they're too sick to show up, and perhaps even people with infectious diseases that then travel, wait until it's too late and then they are traveling around. So I think just commenting that telehealth can definitely have a role to play in all that. I don't know if we have 30 seconds, the fastest question you've ever asked in your entire life.
Hello, cybersecurity. So when I think about technology, I think about cybersecurity because I'm a cyber student. And what kind of a role does cyber play as we try to transform the healthcare and public health into a technological space? So how are we prioritizing cyber as we give people more access to technology and we use healthcare in that field?
Yeah, I think whether it's public institutions or private organizations, we are all struggling with cybersecurity, and this is really going to run toward privacy, trust, patient data, that sort of thing. Again, those worlds are moving very, very fast, but I don't know an organization that is not prioritizing it and allocating resources to it. Is it enough? I doubt it, because the forces that are working against us are very bright people as well. So thank you for that. Well, let me end by thanking our panel for your participation, and on behalf of Texas Biomedical Research Institute, the Board of Trustees, and all the staff and team members, we so appreciate your attendance and support of our efforts in global health. Thanks, guys.